Welcome everyone to our quarterly Global Health Compassion Rounds, which is being jointly convened by the World Health Organization's Global Learning Laboratory for Quality Universal Health Coverage in Geneva, and the Focus Area for Compassion and Ethics, or FACE, at the Task Force for Global Health in Atlanta. The purpose of these rounds is to share experiences, challenge ideas, and spark thinking on compassion in global health. My name is David Addis, and I'm pleased to welcome you to today's webinar. We'll be exploring the points of connection between two movements that have emerged recently in global health: respectful maternal and newborn care and compassion in global health. What do these two movements have in common? What can we learn from each other? What might be possible if we work together more intentionally? To guide us in this exploration, I'd like now to introduce my colleague, Dr. Shams Syed at WHO, who will be facilitating our conversation. Over to you, Shams.
Thank you very much, David, and warm greetings to you all. My name is Shams Syed, and I'm the unit head for quality of care at WHO headquarters. Really delighted that we're having this Global Health Compassion Rounds today, for the reasons that David has clearly articulated. Bringing two communities together with one intention to really think through how our dialogue can lead to action to save lives and improve lives across the world. So as we traverse this Global Health Compassion Rounds, I would certainly encourage us to remember the lens provided by our goal to provide quality of care to people across the world. And when we speak of quality of care, we often describe it as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with evidence-based professional knowledge. Many of you will know that, but now it's our chance to explore that in the context of this Global Health Compassion Rounds. This definition that I've highlighted implies that quality of care can be continuously improved, and importantly, the needs and preferences of patients, families, and communities, as well as health workers providing care, are foundational to this drive towards quality of care. And this is where it becomes critical to examine the intersection of compassion and respectful maternal and newborn care. And indeed, quality of care perhaps provides a nice bridge in the evolving dialogue between respectful care and compassion. And again, this is why this Global Health Compassion Rounds is so intriguing. The discourse between the two communities today can lead to positive effects on the quality of care delivered to mothers and newborns. And so with that, let's get started and listen carefully to the breadth and depth of expertise that we have with us today. And we really are very blessed to have the expertise that we have today. I'm going to start by calling on my dear colleague, Ozge Tunkop, who's a medical officer in the Department of Reproductive Health and Research. You can see her bio in the announcement, but just to summarize, it's impossible to introduce her adequately. But she's a physician and epidemiologist who leads the research, evidence synthesis, and implementation portfolio on antenatal care at WHO, and importantly, has had a key role in the WHO-initiated global network on quality of care that focuses in on the experience of maternal health care, including mistreatment of women and labor companionship. She's been involved and has led many WHO guidelines and guidance documents that are too many to mention right now. So with that, Ozge, over to you.
Thank you very much, Shams, and it's wonderful to be here with you colleagues and to be able to speak here to share a little bit of the journey of WHO and how we have worked on the issue of respectful care and respectful maternal and newborn health. And can you see my slides? Just okay, excellent. And I will be sharing this presentation. I put together some slides to show you a little bit of the history and where we are and where what we've been doing. With many, actually, I was looking at the participants on the call tonight as well. I hope these slides will also be helping to be a signpost for some of the critical milestones in research and resources for us to build on. So with that, I just want to start with this terminology issue, because we have been using different terminology, and I wanted to just head on describe how WHO has actually been evolving in the way we've been using the terminology when we are describing and talking about respectful care. In 2014, we started with disrespect and abuse, the WHO statement, which was the first time that WHO said something about this issue, and the history of respectful maternity care. I know my colleague Elena will be talking about. So I'm just highlighting some of the WHO milestones from our side. But then we said, okay, but how do we define this issue? And this led to a systematic look at the literature. And when I say literature, this is coming from the woman's perspective. How do women view how they are treated during childbirth? And this actually led us to develop a typology and talk about mistreatment when we are describing this phenomenon and actually trying to measure and identify it. But then, like I saw in the note for this panel as well, that lack of mistreatment does not mean respectful care. So then we use the same approach to think about what does respectful care mean. And again, a qualitative evidence synthesis trying to capture the voices of women from the literature in a systematic and comprehensive way, all from low, middle, and high-income countries. And then now, as you'll see in a lot of our documents, we refer to sort of the respectful care, and this is kind of the how we've been using the terminology. As WHO, we have been doing a lot in terms of research, norms and standards, advocacy, and country support. So I'm just going to quickly go through some of the key things. One of which was, as I mentioned, as we said, what is mistreatment? Then we went on to develop a tool to measure it. And we've done this research in 4 countries, Ghana, Guinea, Myanmar, and Nigeria, which actually showed us across the board using this a standardized methodology, what is happening during the time of childbirth. And as you see, I'm not going to go through all of these, but how some of the issues are very prevalent. And one of the things that we were able to look at also was when certain things were happening. When you look at, for example, physical and verbal abuse, how just right before childbirth, 15 minutes before, how these instances of physical and verbal abuse was happening. So to give us a really sort of comprehensive picture of how women are treated and how mistreatment is happening. And then this led us to sort of inform country policies and practices. And you can say, what about newborn? Well, we also, in the observed data for this 4 country, in the 3 of the countries, we actually were able to observe 15 newborn practices, because a lot of the work that we've been doing have been focusing on maternal care, but we, as we are moving forward, want to make sure that maternal and newborn is seen as together, and we are looking at it in a more sort of comprehensive and cohesive way. And we wanted to see what happened, for example, to these 15 observed newborn practices. And as you can see, many of the practices and in terms of evidence-based practices are how they are not happening. And some of we also looked at some of the instances of what mistreatment against newborns possibly might be, and then looked at how it relates to mistreatment of women at the same time. And the results highlight where action can be taken immediately. However, we hope that this work will help us to sort of do more in terms of understanding and naming respectful newborn care, how to better understand women's and families' expectations and preferences, And there is work going on now at WHO to really dig deeper into this with many of the partners in the global health. The other area that we've been thinking about is, okay, we do research, but we also have been thinking about it from the rights perspective, and respectful care is a human right. And how do we think about this? And we've been looking at international human rights and the typology of mistreatment of women during childbirth. How do we align and how do we understand better? And also operationalizing a human rights-based approach where the work that we've been doing have been informing, and we've been working closely with higher level bodies like the United Nations Rapporteur's report on human rights-based approach to mistreatment, and also Council of Europe, where they had a resolution on obstetrical and gynecological violence. These are high-level initiatives, high-level human right-based activities, which we think is really an important component if we are really working towards respectful care, ensuring respectful care. And what about norms and standards? Because this is the other thing that WHO has been doing. And we have been thinking about what is good quality care, as my colleague Shams was describing this. And in 2015, this is the framework that we have established, building on a review of what's been happening and where we are and where we want to go. And here, as you see, for one of the first times where we are not only focusing on evidence-based practices and clinical care, but also taking the experience of care component as a sort of a critical component, a domain of quality of care. And this is important because this leads to a lot of the norms and standards and guidance and guideline documents. For example, the first one was on maternal and newborn care, but it's a continuum of care. So we started with maternal and newborn care, but then applied the same understanding, same conceptual framework to look at the standards for improving quality of care for children and young adolescents in 2018, and more recently for small and sick newborns in health facilities. What about our guidelines? So this also influenced how we have been thinking about developing our guidelines. The first one on the continuum was the antenatal care. And this was one of the first times where we stopped, and I put the review under that guideline. We said, okay, instead of looking at the morbidity and mortality outcomes and prioritizing those, why don't we start with looking into what matters to women during this very critical period in their lifetime? So that review actually helped us to conceptualize and identify and prioritize certain questions, and looking at it from a more comprehensive, person-centered, holistic approach, and led to the 49 recommendations with the title of Positive Pregnancy Experience. And then we build on that, and 2 years later in 2018, then came the Intrapartum Care for a Positive Childbirth Experience recommendations, again, building on the quality of care framework and the person-centered approach and the comprehensive approach. Here you see the recommendations. For example, the first 3 recommendations in this guideline is respectful care, emotional support, and effective communication, among all the other, of course, clinical recommendations as well. And we are thinking of we're doing the same for postnatal care, and now it's going to be launched in January 2022. Again, looking at it from a more holistic and person-centered approach to be able to provide the recommendations in a way that responds to women's needs and what they're saying as well, and what they are what's more important to them. And what does it mean in practice? So this is I want to highlight briefly the Quality of Care Network, which is a broad partnership of committed governments, implementation partners, funding agencies, researchers coming together to reduce maternal and newborn mortality, but also improve experience of care. We've initiated this work with 11 countries, but it's growing. And it's actually an opportunity for us to understand how to measure these experiences within health systems, within quality improvement initiatives. It's not easy. There's a lot of learning to do, and that's something that's been very special and important about the network, to be able to do this with the countries. And throughout this process, a number of critical documents I highlighted here, like the monitoring framework, and also integrating stakeholder and community engagement in quality care initiatives. And also I put the evaluation, implementation, and progress report, which was recently published. And as part of this, I want to highlight the importance of caring for carers while we are talking about respectful care in this sense. And there's been a lot of focus on midwives and how do we improve and enable and empower healthcare providers within the system to also be able to provide the quality of care. And my final thing that I want to say is the next big milestone where we are really trying to go now is, we know there are multiple interventions. We know it needs to be multi-level, but it's beyond service delivery if you really want to reduce mistreatment and promote respectful care. We need to account for the systems level things and society level drivers. And I put some of them here, like harmful gender stereotypes, intersectional discrimination, power dynamics, and the health system conditions and constraints. And of course, participatory partnerships. And I think, speaking of partnerships, that's why being here with the movement of compassion is really, really an important opportunity for all of us. So I'll stop here and thank you very much.
Okay, thank you so much for bringing all of those perspectives through. And there's such a large body of work that you've just described. And of course, if we will definitely share some of the links so that colleagues can have access to some of those core resource documents. If I may just explain what we'll do now. So we're going to go into two overview interventions, one on respectful maternal care from Elena Ativa, and then one on global health compassion from David Addis. Once we've heard from these two colleagues, we'll then be joined by a number of other colleagues in a panel conversation. So as you listen to the colleagues speak, please do type in any questions that you have into Q&A, and we'll try to visit those in the panel conversation. And now, if I may, let's turn to Elena. It's a real privilege to have her with us today, and many of you will know her. She's the advocacy manager for White Ribbon Alliance, a human rights lawyer by training, and she's dedicated her career to preventing violence against women, including in childbirth, intimate partner relationships, and trafficking. And at White Ribbon Alliance, she facilitates the work of the Global Respectful Maternity Care Council and leads global advocacy efforts to strengthen the midwifery workforce and improve reproductive, maternal, and newborn health and rights. So please do take a look at her bio in the announcement for the Global Health Compassion Rounds, because there's lots more to say about her. But more importantly, let's hear from her. So Elena, over to you.
Thank you so much, Dr. Shams, and I'm hoping everybody can see my presentation.
Yes.
And apologies, you can't see me. I'm having some technical challenges here. Thank you very much for the introduction. It has been my absolute privilege to work with the White Ribbon Alliance and to coordinate the Respectful Maternity Care Council. For me, this started very much as a personal experience. So I gave birth 14 years ago, and this is the date when I started also advocating for respectful maternity care. The RMC Council is a multidisciplinary group of activists, professionals, including professional organizations, attorneys, human rights attorneys mostly so, and also other organizations, implementing organizations, grassroots organizations, UN agencies, donors, and others who are stakeholders in this calling for all of us. has started as a community of concern that has grown now to more than 450 individuals from about 45 countries. And it really shows how important this issue is, this problem, and how many people are really dedicating their time to finding a resolution. Özge did such a great job detailing how much we know. We know this is a problem. We know it's prevalent everywhere. We know we have the different types of abuse and mistreatment, and we did a lot of work on that. But what we really need to focus attention on now is the future. What do women want, and what does that future look like? Because I said I've been doing this for 14 years. I'm impatient. Women need decisions and resolutions now because they're giving birth right now. They're relying on those services today. So let me move to my next slide. There's nothing better than hearing it from women themselves. So I want to read some of their words. This is what women want: being treated with respect and tact as a human being instead of as a body, and have the possibility of being provided with good and vast information about my own health to be able to take the decisions I consider as the best for me. This is from a 19-year-old in Mexico. I want to be told what is happening, why is it happening, and to be asked for permission before it happens. A 31-year-old from the United Kingdom. I wish to be treated with love and respect whenever I visit the clinic. A 35-year-old from Nigeria. How do we know this? We mobilized women from around the world, 1.2 million of them, and we asked them a simple question: what do you want for your own reproductive and maternal health care? And you can see where most of the responses came from, but all we know, 114 countries participated, and we saw that there's no really difference between high, low, middle income countries in terms of what women describe that they want. One of their top demands is respect and dignity, and respect and dignity throughout the continuum of reproductive, maternal, newborn, and child care. This movement is older than my own experience, and older than what you might consider the experience of the Respectful Maternity Care Council. It actually started with the humanization of childbirth movement in Brazil, and a very important WHO conference on appropriate technology for birth. Parallel to that, there was a movement in Eastern Europe, where I'm from, starting with the Childbirth with Dignity Foundation, which did a very important campaign in Poland in 1992, together with media. This community of practice, like I said, was formed in 2009, and that grew out to be the Global RMNC Council. One of the most important contributions of the council was the creation of the RMNC Charter, which I'll touch upon in just a few minutes. And that charter was further updated in 2019. And like I said, this movement has grown organically, and we have reached out and really collaborated with those older movements so that we may be able to advance this together. The Universal Rights of Women in Newborns, this is the Respectful Maternity Care Charter. It started as a response to the first 7 types of abuse that were identified, and really focused on what are established human rights. In 2019, we updated the charter because what we found is that while the charter was focusing on both maternal and newborn rights, there were some rights that were not articulated very well for the newborn. It was not clear that the newborn is included. There are also additional rights that apply to the newborn only and had not been previously included. This is a consensus document that was developed by a group, and so many of you are here on the call, of maternal and newborn health professionals, including activists, provider associations, human rights experts, USAID, WHO, UNICEF, and the Office of the High Commissioner for Human Rights. And we're thankful to all of you for your contribution. It incorporates, like I mentioned, rights particularly pertaining to the newborn, like the right to be registered at birth, a very important right that determines whether you can join the rest of the rights articulated in the charter. It does it's firmly grounded in established human rights documents. So there's nothing new about the language of the charter. We just put rights that are already existing in other documents. We put them together in one place, but very much relying on the Convention on the Rights of the Child, for example, which is one of the most widely signed on convention in the world, as well as the Convention on Elimination of All Forms of Discrimination against Women. We as a community have come together to create a theory of change for respectful care with some overarching principles. We know that we have to work at the community level, at the facility level, and at policy levels at the same times to be successful. We know that similarly to the Global RMNC Council, whether we're talking at national or subnational level, we have to collaborate in multidisciplinary groups. It's really important that we all work together because the issue is complex. And also, again, in her last slides outlined, how some of those forces come together. And that's why we need all of us to be contributing and looking at this issue from all different angles. We need community and providers, and we have found this to be extremely successful, to be working for mutually beneficial outcomes. This is really the strategy. It's a win-win. And we are successful when social and gender norms are addressed. We have several strategies that we have found to be very successful, and especially when working together. And maybe there's not one organization that can do it all, but each one of us in our individual work contributes towards one or more of those strategies. And it is how we work together, how we collaborate, that brings about change. We know that we have to work on the demand side to challenge that normalization of disrespect and abuse through human rights. The RMNC Charter has been successfully used to do that, but we know that the first step is really to make sure women, communities, their families and providers understand that these are violations. This is not okay to do. We know that on the supply side, we need to strengthen the whole system to provide high quality, respectful care. It is not really about the providers only. It's not okay to train them on respectful care and send them back to a system that's dysfunctional. This would not be productive. We know that we need to work at policy and legal level and legal redress, and they're needed. These changes and mechanisms are needed to ensure respectful maternity care. And we know that especially important are participatory accountability mechanisms. So where community members, where women themselves participate and they can give feedback, and their voices are really central to the changes. And this is a continuous process. It's not a one-time occurring, whether it's a meeting or a feedback, but really, after something is improved, then coming back again and asking women what they think about it and how, what else can be changed. And we need champions at all levels. And this could look like as an administrator at a facility. It could work as, could look like as a ministry official at the Ministry of Health. It could look like as a media or other champion that has taken up this issue. And those champions, again, at all levels are really critical for the advancement of respectful care. I want to, it's interesting when we prepared for this with David, we had a conversation about compassion and love. And with the responses from What Women Want, we actually have a dashboard, and I'll share the link so you can look yourselves, where we collected responses from those 1.2 million women. And you can search by word or by country. It was shocking to see how many times women talked about love. And I want to mention this because this is not something that this is not a term we generally discuss in meetings like this one. But there were thousands of mentions of love and compassion. And I just wanted to share some of women's words here for inspiration. We need love and good care from doctors and nurses, Cameroon. Love and care from the midwives, Tanzania. Want to be treated with dignity and love, Nigeria. Patients need love and care, Pakistan. Care and love to newborns, Uganda. Show love for the family, Kenya. Love and compassion, Malawi. And one doctor, or a nurse doctor who's doing it very well in India. The behavior of the nurse doctor in our hospital is correct. The doctor's behavior is so good that he writes medicine with great love for everyone. It really made me laugh, but just left such a good feeling. And I want to I want to leave you with this quote from Bell Hooks, who we sadly lost yesterday. But just to finish up, it is love that allows us to survive whole. Thank you.
A fascinating journey that you've described beautifully, all the way from the movement to the natural segue to the next intervention from David. And David, I think more or less everybody on this call will know that David is the director of Focus Area for Compassion and Ethics. He's a public health physician whose interest in the role of compassion in global health motivated him to found the Focus Area for Compassion and Ethics at the Task Force for Global Health. And by background, he's a general practitioner in migrant health, a medical epidemiologist at CDC, and a director and global advisor of neglected tropical diseases programs at the Task Force for Global Health. Again, we could continue with David's background. Let's hear from him on the compassion side, and so completing our loop before we jump into our panel. David, over to you.
Thank you so much, Shams, and thank you, Ozge and Elena, for those just fantastic presentations. And there's so many points of connections that I'm looking forward to exploring. But before we do, I'd like to share a few thoughts from the movement, I guess, maybe it's a pre-movement on compassion and global health. And as Shams often reminds us, we view compassion as having three core elements. And this is based on insights from neuroscience and psychology. But basically, these elements can be boiled down to these three components. First, in order to respond to suffering with compassion, we have to recognize that suffering exists. We have a cognitive attunement with the situation of someone else. Second, with that awareness comes empathy, the feeling what the other person is feeling, in a sense, feeling their pain. This is an emotional attunement. And finally, compassion doesn't just sit with empathy or emotion. It moves into action to relieve or prevent that suffering. So we rely on these three components to guide our thinking and our work in compassion and global health. Now, compassion has always been part of global health, and it's a motivation for many people who work in the field, I would say most, but it's not been part of our discourse very often, similar to what Elena mentioned for love. This began to change a few years ago when Dr. Tedros, the Director General of WHO, included compassion as a central element for quality healthcare. The Learning Laboratory that Shams directs had a seminal webinar on compassion as the heart of quality healthcare services. And this really launched a global conversation on compassion in global health. Now, as envisioned by WHO, compassion is critical at all levels, from the point of care all the way to the global level. And we've already heard about the need for global policies as well as policies and actions that take place at the bedside. Increasingly, national healthcare systems are being brought into this awareness, and they're bringing compassion into their healthcare plans and policies. Now, before the panel discussion, let me stop sharing my slide, and I'd just like to share a few reflections on compassion and maybe some to set up our conversation for the panel. First, it's increasingly clear that compassion is essential for quality healthcare services, and that compassionate care has benefits for patients, for providers, and for health systems. Second, compassion is a core value of global health, and it's a source of motivation for many in the field. Yet this compassionate impulse is often lost in the details and the busyness of our work. So how do we stay connected to it? Compassion in global health is less about righting a wrong than about remembering, revealing, and nurturing compassion that is already inherent in the work of healthcare. Compassion begins from an experience of shared humanity. It's not just a technique. It encourages reflection on why we do our work and how we do it. So compassion is also not just about alleviating suffering. It must also go beyond that to promote human flourishing. What might an explicit focus on compassion contribute to respectful maternal and newborn care? I can suggest a few things and look forward to our conversation together. Compassion is needed at all levels of the health system. It's not just for patients, but also for providers. And we heard Özge mention the need to care for the caregivers as well. Compassion recognizes that we all suffer, including healthcare providers. And this has never been more obvious than during the COVID pandemic. The three-part compassion framework, awareness, empathy, and action, might provide a roadmap for enhancing respectful care. And compassion might provide the inner motivation and commitment and resource to providing respectful care. What can we who work in compassion and global health learn from respectful maternal and newborn care? Well, RMC is much more mature as a movement. As you've seen, there's guidelines and there's recommendations. They're far advanced from where we are on the compassion and global health side. Respectful care is better defined in terms of quality metrics than compassionate care. And the human rights approach is also very important and something we need to attend to in compassion and global health. Finally, what are the themes or concepts that might serve as bridges or points of common ground and understanding in this dialogue? Shams had already mentioned quality could be such a bridge. I believe it certainly could be. That is the quality of person-centered care, which is one of the major domains of quality care. Dignity with its inherent linkages to health and human rights. The ethics of care is also another potential bridge, and then this theme that we've already heard of humanization. With that, I'd like to close, and I look forward to the reflections of the panel and our exploration together. Thank you very much.
Very much, David. There's a bit of an issue with my mute button just there as we get used to our Zoom environment. If I may, we'll now come together in a panel, and I'm going to welcome two further colleagues to join us for that panel. So Özge, Elena, David, of course, and then if I can invite Sheena to join us, Sheena Curry and Damas Dukandane. So before we start the panel, if I might just briefly introduce Sheena and Damas. Sheena is a senior maternal health advisor at JPIGO. She's a British midwife educator and maternal and newborn health expert, and she has helped establish midwifery education programs and associations in developing countries and humanitarian settings. And her background goes back for 20 years in various settings. And again, very difficult to continue that description, but please do look at her bio. Damas, welcome to you. And Damas is from the King Faisal Hospital in Kigali in Rwanda. And he's a consultant physician in internal medicine and medical oncologist at King Faisal Hospital, the largest referral hospital in Rwanda. And he trained as an internist at the University of Rwanda and completed a medical oncology fellowship at Tata Memorial Hospital in Mumbai, India. Again, we could carry on with that description, but we'll pause there. Please do have a look. So before we come back to the colleagues that have already intervened and the wonderful descriptions that they've had, I'd like to turn first to Sheena and to Damas. When you've heard these colleagues speak from the lenses that they come at this conversation from, are there any initial reflections that you'd like to share with the audience? And maybe starting with Sheena and then turning to Damas. Sheena.
So thank you. Good afternoon, good morning, everyone. Warm greetings from Scotland. I see many friends and colleagues in the audience here, and thank you so much for inviting me to be part of this conversation. I think it's interesting when David just mentioned that he feels the respectful maternity care work is quite far advanced. I think it is advanced, but there's still a long way to go with this work. And I think the great work that WHO have been doing in driving this forward, supported by the work of the White Ribbon Alliance, who have led a lot of the advocacy side and listening to women, has really now elevated respectful maternity care to an extent that we're talking about it all the time. And we cannot talk about respectful care without the underpinning of compassion. You know, I was thinking when we talk about, or when we work in any activities related to respectful care, and I do a lot of this in different countries, we often begin with asking people, why did you become a health worker? And it's good to ground people, to help them think back to why did they come in to medicine, midwifery, nursing. And many will say, because I want to help people, or I really care and I wanted to do something for my community. A few say because I want to make money, but not many. The majority are motivated by caring, compassion, and empathy. So that's always a great start. And then we can look at what, and then things happen somehow in their journey of professional socialization that, you know, the road in being compassionate health workers can often change. So I'll stop there. Thank you, Shams.
Thank you so much for starting us off. They're very clear points. Damas, thank you so much for joining us. Really welcome your perspectives.
Thank you very much. This is very interesting. Kerry said about why do we go to medical care? And I remember going to medical school. Here we have to give 3 options of things you want to do. For me, I put medicine, and then agriculture. So I think it starts with the choice. I put two in first place and second place medicine, because I want to make sure that people understand what my choice is. And if they don't give me my choice, then give me agriculture, at least, you know, go grow food, and, you know, because that's what everybody else I think should do. If they don't do what they want, they should go and grow food, because we all eat. So if it starts by a choice, and like David said, and she also repeated it, going back to those roots, because when we talk about compassion, we talk about concern of suffering. And concern of suffering is looking at yourself in that person. And when we, you know, that awareness of the person, of you as a person that is in someone else, and connecting with that, and then taking the action. Because when you take an action with that awareness, you know, you are not going to harm. And medicine says, first, do not harm. So, and I think that's the beauty of it. And like, I think it's Carrie, your name, right? Yes, like she said, all the way, along the way, we lose that. But I think in the beginning, we all have that. And when I think there is so many reasons you can say that people forget this initial thinking, because healthcare becomes so complex. There are so many things that comes in between the patient and the person who is treating. And there are so many factors that comes around what make the person sick in the first place. So it's so much. And when we see the healthcare is only focusing on the outcome, which is what the doctor and the patient do, but they don't look around other factors that intervene in between. So for me, compassion, like David said, I think it's the remedy, because it is something that brings back the connection between the patient and the doctor, because it's not only for the patient, it's also the treating the giver, the healthcare provider, because you're not going, as emotions is the energy in emotion. If you have wrong emotions, if you're not well-centered, you're not going to give the patient-centered care. You have, first of all, to be in the well, in the well state to be able to provide the best. So, and then we can talk about maternal health, like, the subset of the healthcare, but yet all humanity is based on how we are raised. Like that environment that is the womb, the first world a human being lives in. If it's troubled, what are you going to get out of that world? And that's when, like, the smallest part of our inner core life starts, connected with, more than we are connected with the environment with 5 senses when we grow up. When you are in the womb, you are connected entirely. Like, very few things do not cross that placenta. So I don't know how to, but I really like this conversation. I hope it is going to go all the way and bring all of us back to why we do this. Thank you very much.
That's a beautiful description, and thank you for sharing that. We're going to be a little bit controversial in this panel. As David was highlighting, our ethos is to share, which we've done, but we also like to challenge and spark new thinking. So particularly, Eleanor, I know that you're unable to join us via video, but you're of course a part of this panel, so we'll be coming to you shortly. But I did want to just turn to Ozge, Eleanor, and David, just to ask them, when they heard the other colleagues speak from different lenses, if there was any reflection on key attributes of what they were hearing that could support their efforts, and also if there were any points of tension between what they were hearing about respectful maternal care, or whether when they were hearing things on the compassion side, assets and points of tension. So maybe if I turn to Ozge and then come to Eleanor and then to David.
Thanks, Shams, and thanks, colleagues. It's fantastic to hear these thoughts and observations. And 2 things I think I've been thinking. One is, I think it's really important to not think of these interactions as if just between the patient and the provider, and that it's in a vacuum, that it's just happens there, and what are the things that we can do to improve it. I think what I'm hearing from both Damas and David and Sheena and all of us, I think, are there is to have more systems thinking. I'm, for example, thinking of the recent report on WASH. If you are working in a facility with no running water, no functioning toilets. Actually, last week I was in Burkina Faso visiting a clinic providing primary healthcare clinic, providing antenatal care, and using the restrooms, which were not restrooms, and it was the ones for the providers. So they didn't even take me to the ones that patients were using. So, it's so important all of these little things, and they add up. And like Sheena was saying, over the journey, and the same thing from the patient or the user side as well. We're not bringing just our pregnancy or our preeclampsia, or we're not just providing a treatment for preeclampsia or our diabetes. So it's for both of these actors, if you will. It's such a so many things can influence and does influence. So I think one thing that I'm hearing that to me is really kind of where we are converging is it's a systems issue, that we cannot just try to improve the interactions between individuals. It's important, but it's not the whole picture. The other thing that I was thinking, and that's what I came to this, and I thought it would be a tension of when I thought of compassion, I actually thought of it more at the service delivery and at the care provision side. And then David actually showed that slide that said, well, actually, we think of it at different levels all the way to the policy, from the provider and patient interaction on the service point level. And I'm like, oh, wow, exactly. So that's and I never actually thought of compassion from that sort of multi-system level, but it is true. So I'm just going to say what I thought might be a tension actually turned out to be something that we can align on. So I'll stop here. Thank you.
You, Özge. That's really, really important points that you've raised. Just to flag, in terms of the WASH exploration, we actually had a global health compassion rounds that focused in on WASH. So I'll definitely make sure that we have that link to colleagues, because it's an important one. Eleanor, if I may turn to you, I just wanted to make sure that you were able to hear us and connect.
I can hear perfectly, yes, even though
Please, over to you.
So very important conversations also in the chat that I'm following, but as I think the only one who's not a medical professional on this call, on this panel, I've been struck how dehumanizing everything from the training to the actual practice of the different profession actually is. Very often you're asked to forget or forgo your own human needs, the need to sleep, to eat, to go to the bathroom. And then in conditions like Özge described that themselves are dehumanizing. So I'm struggling really, how are we asking people to give what they themselves don't have or don't receive? It's really about, how are we supporting a system of care that takes care of everybody? And so we take care of each other then. And that to me is central. And I don't think it's controversial. I think it's just neat. I think we've come to accept something that's absolutely unacceptable, and it's become the standard. And I don't know if for those of you who are in the professions, it is, become accepted as standard, but I think we have to challenge that. This is not normal. We hear from midwives who have not gone to the bathroom all day, right? This is not human. And so we, or haven't slept, haven't eaten, we cannot be asking people to do that for anything, for anyone. I think what I imagine might be harder for people to think through, and just to say, I'm a human rights attorney, I come from this field, and so for us it's very comfortable to say we have these frameworks, all of these international instruments, they tie to very clear the frameworks at national or subnational level. So if there's a violation, then these are the consequences, and it's a very clear structure to see how things operate. When you talk about compassion or love, and I can just hear in my head people saying, no, this is all fuzzy and warm, but what are you actually asking us to do? It's just I think it's very hard for people to imagine what that looks like. So I can see how this could be challenging. It's not unsurmountable, however. I think it's really about intention, and where do we want to focus attention, essentially? What do we want to achieve together?
Thank you for that. And that fuzziness and warmth of compassion is its asset, but it's also something that can also be a big challenge. And that's where the science of compassion comes in. It's just the right moment to bring David into this conversation. David.
Thank you, Shams, and thank you for this conversation. Ozge, I really appreciated your comment about what might be attention, might not be attention. I think there's some tension still inherent in this challenge we have between sort of the systems approach, which we on the compassion side really need to understand systems. Our biggest barrier is to how to create systems that allow compassion to emerge, that nurture it, that foster it. Most of the studies that have been done on compassion, particularly in healthcare, have been done at the individual level. What types of practices or training might allow providers to become more compassionate or provide more compassionate care? And some of this really focuses on empathy. How do we encourage providers to actually feel the pain of their patients, which we as Sheena mentioned, we become dulled to that through our training. It's beat out of us. So how do we recover that? Compassion really is this internal element. I don't think we can pass a law that requires people to become compassionate. We might be able to alter their behavior, but compassion emerges from, as Damas said, from an encounter with another human being and a realization of this connection. So while we in the compassion work struggle with how to systematize it, we also recognize that there's some degree to which we can't systematize it and just pass it on as a skill that is a performance objective that doesn't come from the person themselves. So how do we wrestle with that? So there's something internal or personal about compassion that needs to be nurtured that might in some ways be impervious to the best systems. On the other hand, we can have the most compassionate person in terms of their impulse and their desire. If you put them in a compassionate or uncompassionate abusive system, it's very difficult. They roll right into moral distress and burnout. So I think we do need both. In fact, this tension is a point of connection and perhaps a point of mutual exploration and insight. But there's something also that is unresolved about those differences that I think we need to find ways to bridge. Yeah. I'm not saying it clearly, but it's more of a feeling. Yeah. Thank you, Shams.
Thank you. Thank you for that. And really, just to think through those assets and tensions is important. I'm going to turn to Sheena and Damas again, really. So the next round, when you heard Ozge, Elena, and David provide their inputs, did you want to come in with any reflections that triggered in your mind, Sheena, and then turning to Damas?
Yeah, thank you, Shams. And I'm following a very interesting conversation as well in the chat box. There's a lot of points coming out. I think I'd maybe like to step back to pre-service education a bit, because that's an area where, of course, professional socialization begins. And I think there's still a lot of work to do in pre-service education in low and middle income countries to ensure that these softer, fuzzy issues are valued, because I think at the moment they're not given the same attention in pre-service education as physical care. I'm generalizing a bit here, but I think knowing of many of the countries I've worked in, that there's still a lot of work to be done although we work with underpinning of ethics, both by the ICM and the ICN, and looking at human rights, there's not opportunities for the learners to really do deep dives and explore these issues, because I think often the faculty that are working with them themselves don't understand these issues very well. And I know in higher income countries, there's been a lot of discussion within nursing and so on this issue of caring cultures. And it's, and we're privileged that we can move and discuss these issues at length in higher income countries. But I think in the lower income countries, there's still a lot of work to do to really elevate the issues we've been talking about here within the curriculum, within practice, and within the support that the students need. So they're encouraged to discuss that. Now, I'd like to bring in another dimension that I think underpins a lot of the problems, which is gender. Oski mentioned it, as did Elena, and we know that gender inequity underpins a lot of the power relationships that impact on the provider's ability to be caring. So if, as much as possible, we have to address gender issues within the curricula for a predominantly female workforce. With all due respect, Damas, I think you recognize that, and all of my male colleagues, there's nurses and midwives are predominantly women, and they experience inequity on many levels, and struggle often to provide care, particularly in humanitarian settings where the culture in many ways is also against them in their ability to be an empowered woman and to feel that they can then bring their caring and professional behaviors into their daily lives. So Damas said it very well. He said it's about being well. You know, if you're healthy, and I think we've seen this with the pandemic, how it's really affected many carers, and we look at the systems that people are working in. So going back to pre-service education, ensuring that students are supported, encouraged to explore the issues that we're discussing now, to be given and to put equal emphasis on the professional behaviours and the caring behaviours as much as the skills and the knowledge pieces. So I'll stop there, and Damas, I'll hand over to you. Thank you.
Thank you very much. Listening to both of or all of us, and when I was trying to bring these things together, compassion in global health and how we give dignified care. It's not easy to teach compassion. Like David said, you have to come to a point where you realize you have to be challenged, you have to be searching and get to a point of recognizing that probably, regardless of how much science you have, we all suffer. And the suffering is not going to stop. But what do we do that we are here? Like between birth and death, what are we doing in between? And what do you decide to do? And I understand that people are talking about how we train. When we are training for endurance. It's like a military. It is endurance. You're going to have to be tough. So I don't think it's necessary to teach you how to be hard on people, but it's how to resist. For me, that's how I take it. I'm not going to say that someone mistreated me and now I have to mistreat other people. It is endurance. For me, that's how I take it. You are a resident. You are on emergency. You have to know that you choose this profession. And I know the people who are mistreating you, it's not that they want to mistreat you, but they want to show you how much this work is demanding. So you come in and you know what is awaiting for you. But it's not, I don't want to think that that is an excuse for me to mistreat other people. No. And when we talk about this compassion and the systems, and we are not going to have a perfect system. We will never be able to have a system where we have everything in place. But how do you do the maximum with the little you have? Like, we are asked to do evidence-based medicine. But sometime in developing countries, you have to go to the second and the third option because you can't afford the first one. But what for me, what I think is the most important, what is their intention do you have when you're doing that? And how do you, like, do you do it for some people and for others? Like behaving the same way between the king and the beggar, having the same attitude, being in the, you know, and for me, compassion is like a compass. It always shows me where is the north. It doesn't say it's a fixed place. No. I can turn around, but always when I stand, I want to know where is the north. How, you know, for me, it is the content and the context. For me, it is more of the container. How do I deliver what I have? It's not questioning, because I know that a perfect system will never, I mean, we all want to have a perfect system, but it's not going to be easy one day. I worked in a rural area. I'm working in Kigali now, which is a nice facility. You can see around. I mean, it's nice, but my heart is at the same place. It doesn't matter that I'm here or I was there. You know, it should not matter where you are. It should be in terms of like, it must be like a compass. You should always find your north. It's not, yeah. So for me, it's recognizing that feeling that we all suffer, like what is the maximum I can do with the minimum that I have. And I really respect people who are looking at the checklist and holding accountable the system. Unfortunately, I'm not that person. I hope WHO and the other people who are like, who want to hold accountable, people who are talking about human rights. For me, I look at the other side of right to humans. Like, how do I reverse those two? The human right is a checklist. You preset what you are looking for, and you hold accountable people who are responsible to provide that. But regardless, you will always have people in those systems, if they are not the right people, if you don't attract the right people, if you don't promote the culture of that compassion, people will do just the minimum required. They, you know, and nature, human nature is weird. We are prone to spend the less energy. So compassion for me is that thing that wakes me up. Like I'm sometimes you in a consultation and you are having a bad day and the patient comes in and you want to reset your compassion and you're like, okay, where am I? I'm not doing well. I'm probably hungry, but how am I going to talk to this person? And sometimes the conversation will not end entirely the way you want. And you can say, oh, come next time. Or I'm sure I'm not getting to your exact point, but can we see? That's how I try to do it. You know, otherwise, we complain a lot about the system. We complain about many factors: patient, poverty, environment, all of that. They are very good people that I respect who are into those things and fighting and advocating. But what do I do in my consultation room? And how do I make sure that what I told the patient is she or he understand it and we are on the same fight? How do I bring her to my fight? How does she understand that I am on her side? how do we make this win-win system? How do we put, how do we come together and then fight and face the problem on the other side, not putting the problem between ourselves, but putting them aside and facing them together, holding hands and looking at the problem together. Thank you.
Thanks, Damas. Thank you, Damas, for sharing that. I'm going to now switch to some of the questions that are emerging from the audience, and there are a number, so we probably won't be able to get through all of them, but I did want to touch on something that Sheena just started to examine in terms of the equity considerations. And there's a number of points related to anti-racism, challenging discrimination in healthcare that has been raised in the questions and also in the chat. So the question is really, when we are thinking about all that has been discussed today, respectful maternity care, compassion side, when we think about anti-racism, challenging discrimination, and reminding ourselves that, of course, equity is a core domain of quality, so there's also that aspect to consider. What are the thoughts that go through your minds as those that have been leading some of this work across the world in relationship to this lens of anti-racism and challenging discrimination? So if I may, I might turn to David first, then to Elena, and then to Ozge for some thoughts on that one. And then I'll come back to Damas and Sheena. So David, please.
Thank you, Shams. This is a real challenge for us in the compassion world, in a sense, because it demands these systems level approaches that we haven't fully developed them from a compassion lens. But clearly, when I look at the inequities of the COVID vaccine distribution, or other inequities in global health that have particularly racial and other dimensions that just scream social inequity. There's clearly a need for a systemic change. And one of the things that we've also seen in the United States in the last several years is that we thought that people's hearts had changed through legislation and social progress, but in fact, they don't appear to have changed very much. So to me, the essence of addressing some of these inequities, like racism, comes to the point that Damas made about recognizing this deep connection that we have with each other. If we don't recognize our interconnectedness, we don't have a deep level of respect. This is where dignity might be a bridge for these two movements. We're not going to address racial inequity without respect, without a sense of interconnectedness and the compassion that can arise from that. Compassion being the desire to alleviate suffering. If we don't care about the other person's suffering, those inequities will persist. So those are some preliminary thoughts. They're not an answer, but I think this is something that we in the compassion world are really wrestling with. How do we think about this? How do we advance our thinking and our interventions along these lines? It's an area of active inquiry and work for us right now. Thank you.
Eleanor, turning to you and then coming to us.
Thank you, Dr. Shams. And I'll build on what David said, but really focus on those structural issues, because we've had some time to think about them, and these are actually built upon the requests coming from the What Women Want campaign. So there were several things that women were particularly pointing to that need to be addressed. First is, as many of you mentioned, just acknowledging that this is happening, that forces like racism and sexism, colonialism, ableism, they impact us today. So that's the starting point, to acknowledge that this is an issue. But there are very practical steps that can be taken to address those challenges. Essentially, women were saying, we want to be treated by providers who look and sound like us. So we need to diversify the professions, really at all levels, recruit diverse professionals and ensure that women are served by people who look like them, including through scholarships or educational programs that provide the means to do so, and ensure that they're then supported to practice. And they also need to be reflected in the composition of regulatory and professional associations, right? Those who set the standards for the professions. So anything from the staff to the board members of those organizations needs to reflect that diversity. There are opportunities also to work with communities to determine what are best practices for anti-racism, anti-discrimination, and bias awareness, and to develop guidelines to improve culturally competent education then for all those who are providing care. So really partnering with the community and ensuring that those communities are heavily involved. And above all, women need to be acknowledged as experts. I think if a woman tells you it hurts, it hurts. It doesn't matter what you think about it. And this is what's been startling to me, part of the discrimination in the United States, thinking that because somebody's skin color is different than yours, they hurt less. And this is, I think, the individual changes that need to happen. But those structural changes, I think, they need to happen first. Otherwise, we cannot see any change at individual level.
Beautifully put, Elena. Thank you. Ozge, turning to you.
Thank you. I think my colleagues covered quite a number of really important points, and I can't emphasize more the fact that this might not be in our generation's time, maybe, but this is something that we all need to work together. And now it's not that it's just happening now, but we are now trying to be aware. People are now becoming more aware of this and talking more. There's so much work going on. I'm thinking of reproductive justice work in academia and in advocacy that we can build on, and we can sort of work together to better incorporate this work that's really happening, this kind of, I don't want to call it a parallel movement, but that movement that's really happening, that's going stronger now, to see how we can actually work together. Because if you look at the data, for example, from the work that we've been doing, it's not just young women or adolescents. It's the way you are mistreated, for example, increases if you're young, and if you're uneducated, or if you are single. So it's so many of these different levels of discrimination that comes up together. And if you look at the United States, for example, it's the women of color. When you look at the data, how they are treated, and the outcomes. So I think the other thing that's really important, that will be really important, is to keep analyzing this data as well, and keep at it to see how we can identify issues so that we can actually be more aware and more proactively work towards them. And I think this is something that's going to be more and more important in terms of both. I'm thinking from the compassion side and also from respectful care side. Over.
Ozge, so the critical importance of equity analysis and prospectively. Damas, briefly, because we want to come to another question when time is running, just turning to Damas and Sheena for any further points on this particular question. I think Damas is frozen.
I'll just speak very quickly, Shams, if I may, because Ozge actually elaborated on the points I was going to raise, which is, I think there is a lot more awareness now. Of course, it's in the media. both the racism issue and the Me Too movement. And I think at a country level also, we're seeing a lot more tribal conflict in many countries. And, that's in many of the countries I work, and Afghanistan comes to mind, of course, where there's been years and years of conflict, and it's underpinned by tribalism. And I think these are deep-rooted values that are very challenging to change. But what I wanted, I think, Damas, I hope he can speak to this, because I think Rwanda is one country where they've demonstrated how they can move on in a positive way from tribal conflict. So I'll stop there. Thank you.
Javath, can you hear us now? Yes, please.
Yes, I hear you. I hear you very well. I think what we unfortunately experience in Rwanda is what David talked about earlier. The collision is a starting point of, I think, cohesion, because you are attracting to something that take away your comfort zone, and in reorganizing yourself, you find a better position. And that comes to another point that I think Elena raised, of diversity. Some people are in one shape of thinking that they don't see what happens somewhere else, and they tend to keep their routine. But diversity is the source of learning, to see that other people are doing something different. And maybe that's something different. When you try, you like it. And so that's in a way of promoting this dignity, compassion. I think some of these things of like increasing number of women, how are you going to say that a woman is capable if you don't give them the opportunity? So, for example, in Rwanda, I remember when, like in 2008, when we were in medical school in this medical student association, copying things from our Senate and member of parliament, where the government said we need to have at least 30%. Then it came down even in the medical student association, where we say, no, in their committee, we need to have 30%. And at that time, some women will be reluctant to, no, we say, this is reserved for you. Nobody else is going to compete for this position. And actually these people, these ladies, they go in and they shine. They shine. It validates their confidence. It shows everybody else that they are capable. And the youngster, learn from that experience. And the man who was so man and thinking that the woman can't do anything, they are challenged. You go home, you see that someone make a better decision than you. Or you just think about a context you would not be able to succeed, and she succeeded. You see, we like taking the advantage of our inner force. Women are different than men. I think in so many ways they have some good quality in a way that, but giving opportunity, diversity to form this human experience and validate some of these values we are talking about. Thank you.
Thank you, Damath. Okay, so we're coming up to the end of our 90 minutes, and I'd like to be respectful of time. There's been a number of questions on capacity building in different ways. So pre-service education has come up in the discussion, but also questions related to addressing compassionate leadership and management practices, as well as how power dynamics are actually examined and looked at within these capacity building efforts. I'd like to turn to all of the panelists to share their thoughts related to, of course, the subject of today, how can we enhance the capacity at different levels of the system to advance the cause related to compassion as well as respectful maternal and newborn care? So maybe if I could, I'd turn to Ozge, Eleanor, David, and then Sheena, and then Damas. Ozge?
Thank you. I actually was going to say something about the pre-service training, but then you changed the question, so now I get to say it.
That's good.
Because I think that's something that's really, really important, especially in health field, where once something is established and or once something you perceive as important or as unimportant, it's really hard to change that in the course of the practice. If it's not something that's given to you in the beginning, and I will give actually an example. For example, one of the things that we looked at is how vaginal examinations are done, because you think vaginal examination, it's so, so much of the examinations done are without a consent, without actually providing for example, the privacy to the woman while there, so that people can see the body parts and stuff. And I remember as a medical student getting the training on these women who volunteer to teach you how to do good vaginal examination. It was such a sort of an important milestone in my medical training, in the sense that they were telling you, okay, now you're hurting me, or now you're doing this. And I was just like, it stayed with me throughout whole of my my career and my, the practice that I've done before joining WHO. It was such an important component of, okay, this is how you do something that some might call simple vaginal examination, but it's such an important part of the care, and that was actually, so I just want to highlight the importance of pre-service training. And when things are highlighted in the pre-service training, it stays with you, as well as the in-service. And in service, I'm thinking of the more kind of the residency training, because a lot of the practices, if you are not seeing them done, for example, I'm thinking of some of the maneuvers that WHO recommends against during childbirth, which are commonly done even in sort of high income settings across the board, because people are seeing what their teachers or their senior providers are doing, and then they just emulate, and then it gets stuck, and then de-implementing them later on becomes so hard. So I think that's why along the way, this is such an important thing to incorporate compassion, respectful care, rights-based care, person-centered care, these concepts from the beginning, from the first year of medical school, if possible, and then throughout as people are going through their clinical journey. So I just want to say that. Yes, and implicit bias training, I see in the notes. Yes.
Thank you, Ozge. Clear. Eleanor, turning to you and then coming to David.
I think very quickly, I think it has to be a whole system approach. It cannot be just one part of the system. And Ozge described it very well. What happens in pre-service training, what happens then in service, what is modeled, right? So I think many people in the chat box also mentioned that, and what is valued, because soft skills are not valued. And I think that's a paradigm change that needs to happen. And only then I think we can be successful. Thank you.
Thank you, Elena. David, and then coming to Sheena.
Thank you. I think students are hungry for this kind of training. They come in with a sense of idealism and motivation that they want this. So I think we need to respond to that desire. Two other things I would mention. I think we need to address this heroic narrative that we have, and we're seeing this crumble now in the COVID-19 pandemic. We go into healthcare, we're the helpers. We don't suffer. We can't afford to be suffer. We're tough because, as Damas said, we've gone through training. That narrative no longer serves, if it ever did. So I think it's recognizing that we also suffer And we need to attend for the patient's benefit as well as ours. We need to attend to that and dismantle this heroic narrative. And that requires setting aside time and space for reflection, for sharing struggles, and for helping each other. And there's very little time for that in training right now. Thank you.
Simply put, David, beautiful. Sheena, and then wrapping us up with Damas.
Yeah, thanks. I'll be very brief. I'd like to just go back to the issue of connections. I think we need to strengthen connections with the students in terms of having a more level playing fields and really ensuring that students are seen as valued members of the team and can contribute to caring and as much as anyone else. I think that's so connecting with their faculty and not having and reducing this power hierarchy that exists and connecting with the women they care for. And I want to put in a plug for midwifery-led care. So for example, meeting the women when they're pregnant, caring for them through their pregnancy, through labor, the perfect partnership where they can really develop empathy and feel they're with that woman, which is really what midwifery is all about. And if we can, I mean, that's moving ahead in some countries now. India is just about to take off with this, we hope. So it's great to see that there's a recognition that if we can connect the midwives and the students with the women, that the outcomes and the quality of care will improve. So thank you.
Thanks, Sheena. Damas, thoughts on this?
I think that there should be clear policy of empowering women as a strong member of our society. And for that matter, any, I would say, marginalized society, because like the vulnerable in our system, there should be policy for protection. For compassion, I think there should be attraction. For example, I would wish to see like WHO and the other big people promoting this in healthcare. Like, I don't know how we are going to, or you are going to make this as, you know, like a value in terms of 1, 2, 3 to quantify it. But there should be a way that compassion in healthcare is monitored, and for me, I think should be top down, because compassion is mostly when you are at the level of dealing with the patient and connecting with them, when you have accumulated enough science, enough experience, and then people who are learning from you, it's a soft skill. It's not something you evaluate 1, 2, 3, but it's something you look from a distance and you recognize that someone is a master. And if you want to be excellent in your care, that's what you want to emulate. That's how you want to look like when you are older. But those people who are there are becoming rare because nobody's recognizing that. I think, see, in terms of patient, for example, it ends up people saying, I don't want to be the bad guy. I don't want, see, you want to fit in the group. I don't want to make everybody else look bad. You know, so you sort of making a coalition, right? You don't want to go an extra mile because you don't want to be looked at someone who make everybody else look bad because of the system and the other things. So there should be a way of, you know, recognizing that and promoting that and making that being safe act to do, and encourage that people, this is the way it should be done. It's not making everybody look bad, but this is how everybody else should do it. Thank you.
Thank you, Damas. I'd like to take a moment to thank all of the panelists. This has been a fascinating discussion. I'm sure that colleagues would agree. This is a really, really active chat going on as well which we haven't been able to fully appreciate, but I'm sure that that will also feed in to the value of this discussion. Before turning it to David to close us out, I just wanted to thank all colleagues for participating. Also, just wanting to remind ourselves, the word love has been mentioned a number of times. It's interesting that we think about different concepts in different ways, but the universality of love, particularly as we come into the season of love, is important for us to remember. Avidis Donabedian, and you may have heard us speak about this previously, but Avidis Donabedian, mastermind behind quality of care, very clearly said, ultimately, the secret of quality is love. And that's coming from a hard-nosed scientist recognized for his scientific examination of quality of care. And perhaps that's something that we should be really thinking about and also taking seriously as we move forward. So with that, again, thank you to the extraordinary efforts from our really distinguished panelists and for sharing their thoughts from different perspectives. As we've always highlighted, we like these global health compassion rounds to share, challenge, and spark. And I think we've definitely been able to achieve that through the wisdom of those that have participated. David, over to you.
Thank you, Shams. And I want to echo your expression of gratitude to the panelists and the speakers who have just been phenomenal. This has been a very engaging and really thrilling interchange for me. So thank you all very much. Thank you, Shams, for your facilitation of this conversation. And thank the audience, all of you, for participating. The chat is really remarkable. There's a question put up, can we share the chat? Yes, we will distill the chat, we'll share that. We'll also share a link to this recording and also a report, as we always have a written report that we send out. It'll take us a few weeks to put that together, but all of you who registered for this will be receiving that. Just a final word, I think we've really touched on some things that are essential to what it means to be human here. And we've seen increasing challenges with the pandemic and other factors, expressions of racism that we were not perhaps prepared for, undermine our sense of common humanity. But there's this tremendous urge to connect. There's this tremendous effort, and the work that's being done in respectful maternal and newborn care is phenomenal in highlighting that connection and bringing out the better angels of our nature. In addition to the words that I suggested that might be bridge terms for us to explore more deeply, dignity, quality, I would add love to that. And I so appreciate the investigation of love from the voices of these millions of women that you surveyed. We need to pay attention to that and understand what would loving care look like, and how do we achieve that and build that. So thanks to all of you. We look forward to being in touch with you for our compassion rounds next year. We don't have the themes lined up, but we hope that you'll join us for the further episodes. Thanks to all. Be well.